I'll share today the basic building blocks of an evaluation for a complaint of knee pain or a symptom around the knee. Like any orthopedic evaluation I do, it's primarily broken down into three main parts. The first being the verbal history. One, I want to collect where all the symptoms are. There are lots of people who present with knee pain, but when you press them, it's also in the ankle and foot, or in the shin, or in the buttock, or in the back, or in the other knee. And those things tell me a lot about whether or not this is coming from the knee itself, coming from the low back, or even the hip, or something else entirely. So getting a sense of where all the symptoms are, what types of symptoms there are besides just pain. One, I want to know how it started and when. I want to know if it's constant or intermittent pain. And I want to know if the patient has noticed stiffness or loss of motion. And finally, I want to know what makes it worse. And when I ask those questions, I tend to get answers to other questions as well, which is great. But those are the main diagnostic questions I want to use. And then I'll ask, of course, questions that rule out red flags, which are unlikely in this setting. For example, an inability to bear weight makes me think of more a structural lesion like a fracture or a major rupture of a ligament. Unrelenting night pain, unexplained weight loss, fever and general malaise, things like that would make me think that that person is in the very small percentage, 1 to 2 or 3% of patients who are having something serious like a fracture or an infection or a tumor. But that's very, very rare. So after the verbal history, we go on to part 2, which is taking the orthopedic baselines or the mechanics. Now, for the baselines, the most important would be the range of motion and strength testing of the knee itself. Because we have two knees, it's great. We can compare to the other side as well, which is important because the difference, even if it's within normal, is usually important. And it's a nice piece of the puzzle to have. So I'll look at flexion, active and passive in supine. The hip is at 90 degrees typically when I do it. Or the femur is flexed to 90 degrees, the hip. And then I'll look at extension in supine too. And I think people often do this wrong. You need to stabilize the distal femur and go under the heel and bring that heel up to see how much extension is present passively. Actively is just seeing if the patient can push the back of the knee down into the table. There's a variety among patients with how much extension they have. That's why comparing it to the other side is really important. But you want it to be 0 or more. Some people have a lot of extension, 10, 15 degrees. So if they're lacking that, then that would be important. We can't just say it's normal if it's 0 or -5 if what they had a couple days ago to their memory, or compared to the other side, it's lacking range of motion. So knee range of motion in supine, we could also do it loaded. If I'm not getting somewhere and I'm curious about what I might be missing, we can look at range of motion in loaded. Strength testing, we can do hip and knee musculature in both seated and supine or sideline, etc., to get the hip abductor. So we can look at knee strength in terms of flexion and extension. We can look at the hip as well. So knee range of motion, knee strength, and if everything in the verbal history sounds like a knee to me, I can leave it there in terms of range of motion and strength. But I usually get lumbar spine range of motion because of the common presentation of a knee symptom coming from a problem in the low back. The XBOS study found that isolated knee pain without contemporary spinal pain was resolved with spinal movements in about 25% of cases. And I did another video about a woman who had knee pain, limping and locking, and it was lumbar. She did have some lumbar pain at that time, but she didn't really think that they were related in terms of pathology. And she may not have mentioned it if I hadn't asked, do you have any low back pain? So I'm going to say lumbar range of motion. And then sometimes I'll also take hip baselines on day one if I think it's relevant based on what I'm thinking again with the verbal history. Or if I get the verbal history and it sounds like a knee and then I start moving the knee and there's no range of motion loss, then I might be more curious about another part of the body as the root cause. So hip range of motion and strength. So for a complaint of isolated knee pain, let's say it's isolated and there's nothing else in the lower extremity or back or buttock, I'm not going to do a nerve tension test usually, but I am going to get a functional baseline. So the functional baseline is when I ask the patient, what can we do here in the clinic that would hurt? Within the patient's tolerance, I want to get that because it's a really powerful measurement to have for cause and effect testing. Oftentimes with a knee patient, it's a squat, a step up or a step down, a certain yoga pose, walking or jogging. I have patients do that in the hallway. That's an option. So a functional baseline is powerful. Get something that matters to the patient if you can. Functional baseline. So when I have all of these mechanics, I'm also putting them together with the verbal history to make me think about what this could be diagnostically, and where I will start part 3. So typically orthopedic clinicians gather these. They may or may not look at the hip or the low back. I would surmise that a lot of them are not, especially the low back. But they'll get these baselines and then their part 3 will be focused on either imaging testing, MRI, X-ray, CT, ultrasound, or orthopedic special tests. So if there's something in the verbal history that really makes me think that there's a ligament instability or something more structural, or a true meniscal tear that's symptomatic and causing the patient's complaints, I might whip out these tests, or I would whip out these tests at this point. So your Lockman, your anterior drawer, posterior drawer, any of the patella tests, any of the meniscus tests like Thessaly, McMurray's. There's a host of different knee tests, and we need to use them when we need to, and we also need to understand how often they can be false positives, incriminating structures that might even not be structurally unsound or problematic, and also finding things that might be structurally not competent for the test, but not the source of the patient's complaint. So orthopedic special tests for me right now are on the back burner, let's say. I haven't whipped one out for a long time. The last time I went straight to orthopedic special tests is when a man presented to me after a fall from a bike, and he couldn't bear weight on his leg very well, and he was missing some range of motion, a considerable range of motion. And I did a varus valgus test, and it seemed like the MCL was torn. So I sent him off to get imaging and a brace, and he did, and it was torn. So, you know, things that you're hearing in the verbal history, baselines that you're taking, especially an inability to bear weight, could be a structural compromise. So the varus and valgus tests for the MCL and the LCL could be employed. So instead, though, my trajectory almost always is repeated movement testing. Now, if something in the verbal history and the mechanical taking is telling me that I think this is lumbar related, I will start with repeated movement testing of the lumbar spine. If I'm leaning towards this is a knee problem, isolated knee complaints are only 25% of the time in the one study coming from the lumbar spine. So that means at least 75% of the time, or close to it, they're coming from the knee itself, if not the hip or SI joint or something non-musculoskeletal. Then I will go to knee repeated movement testing. And I have seen rare cases where we needed a hip repeated movement to restore function to the limb and get that knee pain gone. So I do have to think outside the box a little bit more if it's not knee or lumbar spine. So repeated movement testing in a nutshell is when you repeatedly move the joint and assess for the effect on the symptoms and the baselines. So we could say if there's range of motion loss, if there's strength loss, if there's a functional baseline, let's say walking in the hallway, that produces that pain consistently, then I will repeatedly move the knee into one direction and then retest a few of those key baselines. Now, where I start with my repeated movement test, for example, is it going to be knee flexion or knee extension? And I pretty much start in the sagittal plane of movement and flexion and extension, unless there's a clear deformity, especially in the spine. But in the extremities, there's hardly ever a clear deformity, so I'm almost always starting in the sagittal plane. So whether or not I start with flexion or extension is dictated, again, by the verbal history and the baseline. So if the verbal history is like, every time I do a deep squat, my knee hurts. Every time I get up from a chair, it hurts. Sometimes when I'm sitting at work, it just hurts. And I can't sleep with my legs curled up anymore because that hurts. Well, all those four are obvious. It hurts with flexion. So I would start to think about my investigation of knee extension. But it's not necessarily absolutely like that. Sometimes going into the provocative motion can be the patient's directional preference that solves the joint derangement. But I'm more likely to go, in most cases, opposite what is the cause. So if it's a clear history of flexion of my knee makes me worse, going maybe uphill versus downhill where the knee is a little bit more flexion consistently hurts more, then I would start with extension. Now, we typically, again, start with the least amount of force for safety. So I might start with just long arc quads. So active extension, sitting on the edge of the table, kicking up, holding that quad tight for 5 or 6 seconds, getting to full extension, and then releasing. So maybe doing a set of 10, retesting the baselines. There's other forms of knee extension. So that's the active patient version, seated, non-weight bearing. Then I could also have the patient push the knee into extension and sitting when there's some weight going through the foot. And then there's also standing knee extension where you push the knee all the way into extension or full straightening ability in standing on both feet, and then even more force on one foot. I'm not going to demonstrate all of those procedures right now, but suffice to say that the way I would evaluate is I would pick one of those movements and I would notice what's happening during the motion. Is it painful? Is it tight? The more we do, does it get worse? The more we do, does it get better? I'm taking that information, and then I'm also taking the information by reassessing the baselines and finding out what happens where I go next. So if everything is, the more extension I do of my knee, we've done 20 reps, 30 reps, 40 reps, everything's getting better, well then that's enough information to say let's test it for 48 hours. But if we do extension and it's getting worse, well, I might try a different form of extension because they're not the same. Extension in sitting, where there's no weight going through the knee, is different than extension in standing. So the loads of extension, they're not telling me if someone gets worse with one form of extension or flexion, that I can't investigate another load. But say I've tried 2 or 3 extension loads and they're all making the patient's baselines worse, that would make me think it's time to try a form of flexion, which could be non-weight bearing in supine on the table. It could be semi-weight bearing with the foot on a chair and flexing that knee, or full weight bearing by going into a deep squat. So if I get nowhere with knee repeated movement testing, and it doesn't seem like something else in the knee, right? Maybe the strength testing was normal, so I'm not thinking it's a tendinopathy. Nothing in the history has made me think tendinopathy with like specific patellar tendon pain or pain only consistently with a certain loading strategy. If I'm not thinking tendinopathy and I'm not thinking a structural lesion, and the repeated movement testing tells me this doesn't seem like a joint derangement because it's not changing very rapidly, then I might go to the low back or go to the hip. But repeated movement testing, again, is not just let me see if this is fixable with repeated movements. It's let me see if this gives me an idea that the diagnosis is a joint derangement, because it changes either for worse or for better. Because again, a tendinopathy will not change with repeated movement testing, nor will an infection process, or nor will a meniscal tear, right? But even if I took those orthopedic special tests before, like a McMurray's or a Vesely's or another type of knee test, I could use that as part of my baseline testing to retest to see if it changes. And there's a good case study, I think, by Greg Lynch, looking at a young female swimmer with knee pain who responded to extension, I believe, but she had positive orthopedic special tests that I think for that patient incriminated the meniscus. And after performing repeated extension, the test became negative. So again, we can't really hang our hat on those tests. If we understand that if a joint is mechanically tweaked, those tests can be positive, and it's because the joint is tweaked and not because that structure, like the meniscus, is incompetent and causing the problems. So if I find a repeated movement is fruitful, at least usually 30% is my bare minimum in terms of the general picture, strength, range of motion, baselines, functional baselines. In general, they have to be about 30% better on average for me to have the confidence to say, I really need to know what happens with this when we really do it repeatedly, a couple hundred repetitions over a few days. The dosage is typically 10 repetitions every few hours, which with a knee problem is very easy to perform 10 repetitions in a minute or so. The dosage matters. It can't be 100 repetitions in the morning. The frequency part of the dosage is really crucial to understanding how this joint is behaving. And again, if I find that repeated movement testing does not consistently change nor keep better baselines, then I will go back to, well, if it's not a derangement of the knee joint, what else could it be? And tendinopathies in the patellar tendon are common. There's usually a clear picture of that in the verbal history and in the baseline setting that we could provoke that tendon with a specific load, and there's not typically a range of motion loss. So there's different pathologies of the knee, but I find a lot are knee derangements. Just like in the spine, I find a lot of problems that patients have are just the joint being mechanically a little tweaked, and we can fix it by finding the motion that we need to kind of get it back on track. One analogy I use with patients sometimes is the kitchen drawer. Sometimes you try to close the kitchen drawer and it just doesn't go, and then you wiggle it and then it goes. And what's happening mechanically, we can make guesses, but I can't tell you firmly exactly what's happening in the knee joint or if it's exactly intra-articular or not. But if you're struggling with knee pain, I recommend finding a clinician who uses repeated movement testing as part of their orthopedic evaluation and possibly subsequent treatment, especially if you've already seen an orthopedic-based clinician, physical therapist, chiro, trainer, orthopedic MD, etc., who hasn't used that kind of understanding of the musculoskeletal system, because I use this rubric because it gives me the best outcomes for patients. So another option is getting the book Treat Your Own Knee. It's not expensive, it's online, and it goes through how to assess by using different repeated movements if your joint being mechanically deranged is the cause of your problem, and if it is, how you can self-treat it with attempting different repeated movements. If you have questions, please leave them in the comments and I'll do my best to answer.